Yes, we can see it, but it's not in full screen mode. If you can
Full
make
screen
it,
is like
yes.
this.
Yes, that's perfect.
Okay.
Now it's perfect. Yes, good. Mm.
Should I stop the screen sharing or anybody wants to?
Yes, can stop now. I'll check if Dr. Abshirin is here. He will be moderator, so he can introduce you. Then we can start. Let's check. Yes, he's already here. Dr. Aib,
Hi,
how are you, Doctor?
I am in a meeting actually. So I was in the World Neurosurgical Conclave. So I had a panel discussion on exoscope versus endoscopes, exoscopes versus microscopes. So I was there actually. That's why. So I just got out and I thought I'll just attend this. I may not be able to attend this for the full time, but whatever time I can attend, I'll attend, and then we'll start it off, and then we'll go ahead.
Okay.
Okay.
Now I will do welcome to the audience, and then you can, Dr. Aib, you can introduce our speakers, and then we can start.
Okay. Should I start or should we wait a little?
No, you can start,
Okay.
please, because
So welcome,
So, first of all, thank
welcome
you.
everyone. Dr. Abbas, I will do introduction. Uh, welcome all to the ninth session of the Comprehensive Neur-Anatomy Educational Course organized by the American Neurosurgical Society in collaboration with the World Federation of Neurosurgery and the Young Neurosurgery Forum, along with the Neurosurgery Coach and the Pakistan Society of Neurosurgeons and Neurosurgical TV. Today we will have two distinguished speakers, Dr. Eduardo Ribas. He will talk about amygdala, and Dr. Eileen Kuzuk. Did I pronounce it right, Doctor? Dr. Eileen?
Pelin.
Eileen Kuzuk, yes?
It's good.
Yes. Okay. So our moderator today will be Professor Abcherian, head of director of Institute of Neuroscience at Krishna Peshawar in Karad, India, and founder of Neurosurgery Coach. Dr. Aib, please, you can introduce our speakers.
Well, thank you very much. It's a great honor. Ahmed has been with me about 7 years back as our fellow, and I'm very proud of where Ahmed has come to. And Eduardo Ribas, I have heard about him a lot, and I really appreciate the work that he's doing, excellent work that he's doing. Eileen, unfortunately, I don't know her very much, but I would ask Eileen to enlighten a little bit more about her to us so that we know. Unfortunately, when I agreed, I didn't know that my session is going to be today. I knew I was in Delhi, but I didn't know the sessions were going to be today. So I just had one talk, and then I had this session on exoscopes. Extremely interesting. We have a lot of guys here. Charlie, everybody was here. So, but I would ask Ribas to his talk, and then maybe Aileen to shed light on her work as well. And again, I'm honored for this. Thank you very much.
Thank you, Dr. Aib. Thank you very much. So now our first speaker will be Dr. Eduardo Ribas, Associate Professor and Neurosurgeon at Faculty of Medicine, University of Sao Paulo. Doctor, will talk about anatomy of the amygdala. Please go ahead, Professor.
So thank you. Hello, everybody. For some are still in the morning, for others are already at night. I feel very, very happy to be here with you, with friends. In the last years, I came up with so many friends around the world and traveling and talk about neuroanatomy, more specifically how neuroanatomy can help our neurosurgeries. I believe most of us here are neurosurgeons, but anatomy is good for a lot of other professionals as well, right? But in my talk, I'm gonna talk about neuroanatomy, but how to apply this into our surgeries, into our neurosurgeries. And also, I'm very happy to be with people from all around the world. This new age, this new era that we are, and we can talk and we can share experience, we can share knowledge, and huge countries all around them from Brazil. Dr. Pelin is from Turkey. People from India is here too. And so huge countries, a lot of neurosurgeons is very, very good to help everybody. So here in Brazil, I work in two main places. I work at the University of São Paulo. São Paulo is the biggest city in Brazil. And in the afternoons, I go to the Albert Einstein Hospital. It's one of the major hospitals that we have here, and I'm very happy to work on those two places. But my anatomy research I did under Professor Rotten from 2012 and 2013. I did this long fellowship there. It was a very good experience that I had to put together all the neuroanatomical knowledge and now to apply it into our surgeries. Now, today we're going to talk about the amygdala, and the first slides I'm going to just show to you guys where the amygdala stays inside our brains. So this is the lateral surface of the brain. We'll see the Sylvian fissure at the center of the surface. And if we split the Sylvian fissure, just retracting the opercula, we will face the insular cortex. The insular cortex has been said by some to be a shield for the neurosurgeon, not to get deep to the insular cortex, just if you need, just if it's harboring gliomas, for example. And why is that? Because the insular cortex is the outer surface of a complete different compartment of the brain that will have a lot of eloquent nuclei and white matter fibers. This place is known as the central core because architecturally a lot of structures is putting together inside the morphological center of each hemisphere. So that's why we say it's the core, it's the central core of each cerebral hemisphere. But I would agree that that's perhaps not the best name because we are putting together a lot of different structures, but all of them has a lot of functional significance. So every neuroanatomy book will have this axial cut of this region, that we have this alternating gray matter with white matter, gray matter and with white matter. We're putting together so basal ganglia, white matter capsules, and thalamus is the main structure of the diencephalon. It's very interesting that each central core is at the morphological center of each cerebral hemisphere. And some structures are around the central core. They are called limbic because they are around. More specifically, around the thalamus. The thalamus is the main structure of the central core, as I showed. And around the thalamus and the central core, some structures have folded, have bended during the development of the central nervous system. And by this bending, it has this C shape that we call limbic. So let's take the brain and just fold it a little bit, tilt it a little bit, and we can see the C that makes the limbic system. We have some Cs. I'm just going to pinpoint two of them. We have an outer one called the cortical C of the limbic system that is made by the cingulate gyrus. Its narrowing called the isthmus of the cingulate gyrus, and then its continuation that's called parahippocampal gyrus. It's called parahippocampus because it harbors the hippocampus inside. So the parahippocampal gyrus continues with the isthmus that continues with the cingulate gyrus, creating this cortical C or outer C of the limbic system. And then inside the parahippocampal gyrus, we will have the amygdala and the hippocampus. Specifically at this point where the parahippocampal gyrus folds over itself, creating a hook-shaped place, it harbors anteriorly the amygdala and posteriorly the head of the caudate, the head of the hippocampus. And the hippocampus continues more posteriorly into the parahippocampal gyrus also, and then its fibers converge, forming the fornix. They will make all this C around the thalamus and finish at the mammillary bodies. So this is the limbic areas that I removed from this brain here. So we have the septal region, we have the cingulate gyrus, the isthmus of the cingulate gyrus, and the parahippocampal gyrus. This is the outer C that I talked about. If we just flip it the other way around, we will see that inside the cingulate gyrus, we have the cingulum, is a set of fibers inside. And inside the parahippocampal gyrus, we'll have the hippocampus and the amygdala. And as I said, the amygdala is more anterior than the hippocampus. The amygdala is just over the head of the hippocampus, just like a hat. But I would say it's just like we say a French hat, because it's not just over the head, it's a little bit folded anterior and medially. So it's not directly anterior, it's anterior and medial. This is that because the neocortex, the lateral part of the temporal lobe, developed so much and pushed the amygdala and the hippocampus to inside the brain, to the more medial compartment of the brain. So they were displaced more inside. And what I want to show in this picture also is that these structures are inside the temporal horn of the lateral ventricle. And as you can see, the temporal horn finishes here. So the amygdala is the anterior part and the anterior lateral part of the tip, the anterior tip of the temporal horn. The temporal horn finishes here. Between the amygdala and the head of the hippocampus, we'll have a cleft, we'll have a space. It's called the uncal recess. We can see this in MRI exams, and we can also see this in surgeries. This will help the surgeon to distinguish what is the amygdala put anteriorly and superiorly from what's the head of the hippocampus. And the hippocampus, also a limbic structures, has three parts. I think Dr. Panning will talk about this later. But these fibers will condense into this other C. And the thalamus will be inside here, and the thalamus is said to be laying on this surface that's called the subiculum. Why this is important? Because the amygdala will have connections with all these limbic structures. That's why I'm just showing them a little bit. It will have some connections to them, to the hippocampus, to the subiculum. This is a superior view of the hook that makes the uncus. And I want to stress this part, put attention on this part, that the anterior part of the hook harbors the amygdala, and the posterior part will harbor the head of the hippocampus. And the fibers of the hippocampus will get together and form the fornix. And the thalamus will be in this space here, laying over the subiculum. And we're just gonna that between the subiculum and the fornix will have some dentate gyra here. But at this lecture here, I'm talking about the amygdala. The amygdala and the fornix, they are putting together at the temporal horn. But between the amygdala and the central core, there is no subdivision. The amygdala continues itself with part of the central core, more specifically with the globus pallidus. There's no cleft here. More posteriorly, you see a cleft. This is the choroid fissure. This cleft will help the neurosurgeon because this cleft divides medially the thalamus from laterally the hippocampus. So posterior to the amygdala, there is this cleft that will help the neurosurgeon or whoever is working inside there that wants, for example, to remove the hippocampus, but not to remove the amygdala. For example, temporal mesoesclerosis, that we want to resect these structures. The choroid fissure will help you to get to know where the hippocampus is. But what about the amygdala? The amygdala continues superiorly with the globus pallidus. There's no cleft between them. They just continue. So you here and at the right side is drawing, and at the left side, my picture here, the amygdala, as I said, is superior and medial to the tip of the anterior horn. So this is the amygdala. and the amygdala continues with the globus pallidus. Okay, this is the lentiform nucleus. Laterally, we have the putamen. Medially, we have the globus pallidus. So they two continue like the number 8, or like a snowman, where the head of the snowman is the globus pallidus, and the body of the snowman is the amygdala. The amygdala is not just one nuclei, it's made by several nuclei. We can distinguish 30 different gray matter areas inside the amygdala. But these these are grouped into bigger regions. And nowadays we just divide them into the dorsal medial group that's here. So you understand that it's very more medial, just more here, I would say. And this is the part that really continues more medially. As you can see, some people say the extended amygdala, because this part of the amygdala can continue with the substantia innominata and later continue with the bad nucleus of the striatum terminalis that I'm going to show later. So some people will not claim the amygdala finished here. It extends even more medially. So we have this central medial, the dorsal medial group. Then we have the central nucleus more superiorly, and we have the basolateral group. The basolateral group is more lateral, and some people will say it is a more neocortical structure, although it's not neocortex per se, is really connected to the temporal lobe, is really connected to the neocortex. So if you ask what is the neocortical area of the amygdala, that's the lateral part, because it's more connected to the temporal lobe. The amygdala, as I said, it is the anterior part of the uncal notch, right? And the amygdala receives a lot of information. It receives, for example, olfactory information. Olfactory tract posteriorly is subdivided into 2 strias, the medial one and the lateral one. The lateral goes laterally and then finished at the amygdala. So it has an olfactory connection here. It also has a dorsal connection that we call dorsal amygdalofugal fibers. I don't really like this name, amygdalofugal, because these connections are usually reciprocal. Information comes out and comes in, so they are afferent and efferent at the same time. These dorsal, I would say, amygdalofugal fibers, they are called the lamina terminalis. This is going on the space between the caudate and the thalamus, called the striothalamic nucleus. I'm going to show this a little bit later. And this has also ventral connections, ventral amygdalofugal fibers, that the old anatomists would call them the ansa peduncularis, because they are making a C-shaped, a turn around the cerebrus peduncle, the cerebral peduncle, the anterior part of the mesencephalon. But nowadays we can distinguish them into 3 components that I'm going to show later. Okay, so we have the lateral olfactory stria, we have the stria terminalis, and we have the ansa peduncularis. I'm going to show them a little bit more. Okay, the olfactory tract opening the olfactory stria, and they are the anterior part of the anterior perforated substance. So whenever you see the anterior perforated substance, you see the olfactory stria more anteriorly, and then we have the anterior perforated substance, and the amygdala will be at the anterior part of the uncus here, so it's going to be here. Then there is a connection of the lateral stria going inside here to the amygdala. About the ansa peduncularis, we did this nice study where we could put tractography, very fine tractography, and to distinguish the subcomponents of the ansa peduncularis. So in the old anatomies, we'll just say this is one part, but we can distinguish them. The most known of them is the amygdaloseptal connection. The amygdaloseptal connections is also called the diagonal band of Broca, that also harbors some gray matter. So also a continuation of the amygdala to the septal region. There's 2 other connections: amygdalo-hypothalamic fibers and amygdalothalamic fibers. Amygdalothalamic fibers, they are going to the thalamus, so they can be called a thalamic peduncle as well. They're going to get connected to other fibers, but some people say it's extracapsular thalamic peduncle, inferior extracapsular thalamic peduncle, because it's not between the length form and the caudate. This is another way of seeing this, but this is a connection of the amygdala to the thalamus. And as you can see here in our work of the DTI, 3 of them, they begin at the amygdala. These are the ventral amygdalofugal fibers known as dansa peduncularis, but nowadays that can be distinguished into these other tracts. This is my dissection. We are seeing the anterior perforated substance from superiorly, not from inferiorly. More usually, we are seeing the anterior perforated substance from superiorly, from underneath, right, from inferiorly. But at this dissection here is from superior. So we have all these perforating branches going through the anterior perforated substance. And I wanna stress here are these fiber connections here, coming from the amygdala laterally to somewhere medially. Where they are going to 3 places. They are going to the septal region, they are going to the hypothalamus, and they are going to the thalamus. Okay, the septal region is what we call the diagonal band of Broca. Okay. And now let's talk about the dorsal amygdalofugal fibers. The dorsal amygdalofugal fibers is the Hysteria terminalis. This is here colored in orange. So this is a dorsal connection of the amygdala that's going to make a very long route at the striothalamic sulcus. Striothalamic sulcus because it's between the caudate and the thalamus. It will make also a C shape. So it's limbic. It's a C shape. It's around the thalamus. That's why it's limbic. It's around. And this C-shaped structure, the Hysteria terminalis, will finish underneath the head of the caudate at a place called the bed nucleus of the Hysteria terminalis. As I said, the bed nucleus of the Hysteria terminalis can connect to the amygdala. There is a connection from medial to lateral that some people call, for example, Leonard Heimer will call this the extended amygdala. As the Hysteria terminalis reaches the anterior commissure, it subdivides into a precommissural segment and a postcommissural segment. The precommissural segment that is anteriorly will go to the septal region, and the postcommissural segment will go to the bed nucleus of Hysteria terminalis. Okay, and this is what can be connected without a really gray matter connection between the medial bed nucleus of the Hysteria terminalis to the lateral position amygdala. This is another picture of that connections at this great book. I love this book, The Human Central Nervous System by Neu Hoy. So whoever is studying neuroanatomy, functional neuroanatomy, has such good writing and very good illustrations. So you see the Hysteria terminalis coming here, opening a precommissural and postcommissural segments. The precommissural goes to the septal region, and the postcommissural goes to the bed nucleus of Hysteria terminalis. And then it can be really connected to the amygdala without interference, really connected. The anterior part so goes to the septal region. They have many nuclei that is connected to, but the posterior one will go to this place 4 and 5, that is the bed nucleus of the Hysteria terminalis. Okay, and then it has also neocortical connections. It has connections to the temporal lobe, it has connections to the insula, and it also has connections to the hippocampus and to the subiculum. So it's really well connected. When I say afferent, usually we are putting together afferent and efferent, because as I said, a lot of connections come and go. They are reciprocal. Another interesting fiber tract at this location is the ansa lenticularis. The ansa lenticularis is not connected to the amygdala, but it will join the ansa peduncularis for a short distance. So while the ansa peduncularis that I said before is beginning at the amygdala, the ansa lenticularis is shorter. It does not go to the amygdala. It already starts at the GPI, the internal the globus pallidus internus, okay? And from the globus pallidus internus, the ansa lenticularis will make a route anterior to the internal capsule, and then continue to the red nucleus, to the substantia nigra, and to the subthalamic nucleus. There's 3 parts of this ansa lenticularis, and it will join the ansa peduncularis. So this is another work that we did with some Chinese friends. There, here we put the ansa lenticularis. So the ansa lenticularis is not beginning at the amygdala, but those fibers are really together for a short distance with the ansa peduncularis. So some people will say the ansa lenticularis is part of the ansa peduncularis, but they are in fact a little bit different because they have different origin and different destination. The destination of the ansa lenticularis will finish so at the red nucleus, at the subthalamic nucleus, and at the substantia nigra. Okay, this is just some illustrations that we did. Inside the amygdala, all these nuclei, they connect themselves, and there is a progression of this connection from lateral to medial. So the information comes from lateral to medial. Okay, this is important from the functional point of view because they are not reciprocal. They do not come both ways. So the information that comes from lateral, it finishes more medial. And then the information gets out. As I said, most of the connections are reciprocal, but the spread in the efferent system, it goes to more regions than the afferent system, mainly to frontal regions also. This is a brain dissection where we split the Sylvian fissure, and then we open the temporal horn. The temporal horn can be opened by many ways. Here we are opening the inferior limiting sulcus that Professor Yashagil calls the transinsular approach to the temporal horn. And as he's doing this cut at the inferior limiting sulcus of the insula, he will see the amygdala much more anteriorly. So if a neurosurgeon wants to do selective amygdalo-hippocampectomy, for example, to treat mesotemporal sclerosis, to treat epileptic seizures, he does not want to make this cut too long. He can make a cut just superior to the amygdala. Where he's going to make this cut? Directly inferior to the limit insula, where the limit insula joins the inferior limiting sulcus, a little bit underneath and a little bit more posterior, you will see the amygdala. If you go more posteriorly with this cut, you will meet other fiber pathways. I'm not going to talk about them, but you can visit this paper that we have. So the surgeon who wants to do, I would say, a more direct route to the amygdala will keep himself at the anterior part of the inferior limiting sulcus and not go very, very posterior. Once the surgeon gets inside the temporal horn, he will locate himself. As I said, between the hippocampus and the thalamus, we'll have the choroid fissure. This is more easily to understand where the surgeon will stop his resection. He will not go more medial than the choroidal fissure. But what about the amygdala? As I said, the amygdala continues itself with the globus pallidus. So where will he see that he will end his medial disconnection of the amygdala? Well, some people like Dr. Wen, I work at the University of São Paulo, and I learned so much from Dr. Wen, Brazilian neurosurgeon dedicated more to epileptic treatments. So he will look for this point here. This is the inferior choroidal point. This is where the anterior choroidal artery gets inside the temporal horn. He will look for this point inside the temporal horn, and he will see or the ICA bifurcation or the band of the pia mater overlying the amygdala here, and he will make a cut here. This cut will be just lateral to this artery here. This is the anterior choroidal artery that is beginning in the ICA and getting inside the temporal horn. So by this cut, he will disconnect in the amygdala that is kept laterally from the globus pallidus that is kept inside the central cord. This is one way of doing this. Another way of doing this is to look for this structure here that's coming from the optic chiasm to the lateral geniculate body. This is the optic tract. So this is another way of understanding where the amygdala finished and where the globus pallidus will continue itself. So the surgeon needs to do this cut lateral to the optic tract if you see this into surgery, okay? So this is a QR code. If you guys want to see the articles that I put together to do this talk, or I can put the link here if you guys want to reach these articles. Okay, so thank you. If some questions, or we keep the questions after Dr. Pelling's talk.
Thank you very much, Professor Rebus, for this fantastic presentation and very nice this exchange. And there is a lot of information that you explain the anatomy and the physiology and also applied anatomy of this amygdala. Unfortunately, Dr. Aib Shirin couldn't stay with us. And for any questions for Dr. Rebus, please, I encourage your audience to add their questions in the chat. And after we finish with our second speaker, we can discuss if there is any questions. Okay. So now we can move to our next speaker, Dr. Belen Kozok. Dr. Belen is a chairman of the board of directors of Turkish Neurosurgical Society and Neurosurgeon and Young Neurosurgeon Board. And she is also assistant professor at Gazi University at Neurosurgery Department. Dr. Belen also was awarded the Dr. Gazi Sergil Young Neurosurgeons Encouragement Award. And we hope he will give us a presentation about the fiber tract anatomy of the hypothalamus. Doctor, please go ahead.
Thank you. Hi, dear colleagues. Today, I will try to give you information about the hypothalamus anatomy, nucleo, and tract, which is the main subject of our article published in 2021. Let's start with definition hypothalamus. The hypothalamus is approximately 4 cc collection of neural tissue, or in the other words, about 0.3% of a normal adult brain volume. Despite its small size, it's a collection of nuclei with a crucial role in the regulation of autonomic endocrine role and regulation the other things, behavioral states. It's an important junction in the communication between the brainstem and the cerebral cortex. However, it has been used as a target for obesity, behavioral disease, headaches, and movement disorders. The white matter connectivity, the hypothalamus, is still incompletely now, If we look at its function, it's mainly regulation of endocrine functions, body temperature, hunger and food intake, thirsty control, and of course, involved in Papez ring, which is an important part of the limbic system and has role in emotional and behavioral states. If you look at the borders of the hypothalamus anatomy, anterior optic chiasm, perioptic area, and lamina terminalis. Superior thalamus and subthalamus, inferior infundibulum and pituitary gland, posterior border of the mammillary body. The hypothalamus contains many functional nuclei. These are paraventricular, suprachiasmatic, perioptic, supraoptic, anterior hypothalamic, infundibular, ventromedial, dorsamedial, lateral, hypothalamic, posterior hypothalamic, and mammillary nuclei. If we look at it one by one, first, paraventricular nuclei is located in the anterior hypothalamus. You see. The main controller of the autonomic system produced the secretion of corticotropin-releasing hormone, oxytocin, and vasopressin. The other one, suprachiasmatic nucleus, is located again anterior hypothalamus. It coordinates the endocrine, psychological, and behavioral circadian rhythm. The other one, perioptic nucleus, again located in the anterior hypothalamus, and it takes parts regulating body temperature. Supraoptic nucleus is located in the anterior hypothalamus and controls the secretion of vasopressin. Arcuate nucleus or infundibular nucleus is located in the inferior region, and it takes into account the regulation of satiety center. Ventromedial nucleus is located the posteromedial region. It regulates food intake. Dorsomedial nucleus located in the posteromedial region of hypothalamus. It's regulating body blood pressure, heart beating, and digestive system. Lateral hypothalamic nucleus is located in the lateral hypothalamus, and it regulates food intake and body weight. Posterior hypothalamic nucleus is located posteromedial hypothalamus, and it control of meiosis, mydriasis, and sweating. Again, here we see the hypothalamus and its radiological image, and we see anterior commissure, posterior commissure, and blue area hypothalamic area, and on radiological image. We see optic nerve, mammillary body, posterior commissure, anterior commissure, and hypothalamic area. And again, hypothalamic area we see. Now, I will try to explain the white matter tracts around the hypothalamus with the white matter dissection and the tractography, DTI. Dissections were performed from lateral to medial, medial to lateral, superior to inferior, and inferior to superior. First tract, cingulum. We see medial view of the brain specimen. The cingulum start from the anterior part of the parahippocampal gyrus and extend to the subcallosal cortex so that it reaches the anterolateral hypothalamus, and we see a green one, cingulum fibers, and DTI images. Cingulum is responsible for the limbic pathway, emotional regulation, and bladder control, you know. And the other one, fornix, again, we see the medial view of the brain. The fornix is a large, compact arch-shaped bundle arising from the hippocampal formation and directed to septal region and hypothalamus. The columns of the fornix fiber extend from the anterior and medial hypothalamus before terminating in the mammillar body. The fornix consists 4 parts: crura, commissure, body, and columns. And the posterior fibers of fornix called the posterocommissural fornix. It continues through the anteromedial hypothalamus to end on the posteromedial surface of the mammillar body. We see dorsal and medial longitudinal fascicle. The blue one, dorsal longitudinal fascicle, travels over the ipsilateral pontine tegmentum and midbrain to reach posteromedial hypothalamus. It plays a role in transmission of the motor and sensory signals. The orange one, medial longitudinal fascicle, is a group of fibers that extend between the periaqueductal gray matter and interstitial nuclei and reaches the posteromedial hypothalamus area. It coordinates the conjugate movement of the eyes and associated head and neck movements. Medial forebrain bundle, the yellow one, we see the yellow. It connects the hypothalamus to the septal area. The rostral origin of the basal forebrain bundle is a mutable olfactory region, septum, nucleus accumbens, passing through the anterior part of the hypothalamus towards the posterior associated with its lateral part. It controls behavioral state. Mammillothalamic tract is an important part of the Papez circle, and it originates from the anterolateral surface of the mammillar body and reaches the anterior thalamic nucleus and extends into the superior and inferior hypothalamic area. It provides memory processing and limbic pathway. The fasciculus retroflexus is located lateral and posterior-inferior to the mammillothalamic tract and connects to the posterior part of the hypothalamus and to the red nucleus habenula and interpeduncular nucleus through the epithalamus. It runs posteriorly between superior to inferior hypothalamus. The blue one we see. Mammalia tegmental fascicule originate at the junction of the mammillar body and mammillar princeps fasciculus and extend to the tegmentum. This tract is a small efferent fiber bundle that extend to the posterolateral hypothalamus. Its function is not known exactly. The fasciculus mammillaris princeps, which contains the efferents of the mammillar body, is a large compact bundle of fibers that pass a short distance laterally and then into two components, the mammillothalamic and the smaller mammillategmental tracts. The internal capsule, includes the frontopontine tract, temporoparietal occipitopontine tract, corticospinal tract, medial lemniscus, spinothalamic tract, and thalamic radiation fibers. The anterior leg of the internal capsule passed anterolateral to hypothalamus, while the other parts of internal capsule, the geno, leg, retro and sublenticular parts, pass through the posterolateral hypothalamus. It's important track. And the other one, diagonal band of Broca, connects the gyrus paraterminalis with the amygdala and anteromedial hypothalamic region. Its regulation of cognition and emotions. Ventral amygdalohypothalamic fiber extend from the dorsamedial part of the amygdala to the optico-hypothalamic region at the line Broca's band. Its control of behavioral state again. The other one, stria terminalis, connects the amygdala to the hypothalamus via the perioptic and septal areas and runs in a C shape in the stria thalamic sulcus. It is associated with the anteromedial part of the hypothalamus. Frontopontine tracts, the internal capsule's fibers pass through the anterior parts and extend to the anterolateral hypothalamus, connecting the frontal lobe and to the midbrain. It provides visual and motor control. The other one, corticospinal tract, extends from the primer motor and supplementary motor cortex and parietal lobe along the brainstem and into the spinal cord. Its fibers pass through the internal capsule and extend to posterolateral hypothalamus. It provides limb motor controls. The other one, temporoparietal occipitopontine tract, extend lateral to cerebellar peduncle posterior to internal capsule and connects the temporal, parietal, and occipital lobes with the pons. It provides motor control again. The superior cerebellar peduncle arises from the dentate nucleus and terminates in the contralateral red nucleus, thalamus, and posterolateral hypothalamus. It provides motor control. The medial lemniscus, we see the different color, all of them. The medial lemniscus or rails band is a bundle that ascends from the nuclei of the cuneatus and gracilis, and after crossing the medulla oblongata and passing through the posterolateral part of the hypothalamus to the ventral posterior nucleus of the thalamus, arrive relevant information to the posterocentral gyrus of the cerebral cortex. The yellow one, spinothalamic tract. The ventral spinothalamic system joins the medial lemniscus from the medulla and pons, and together they extend to the thalamus sensory cortex. In our study, it was not possible to clearly define the borders between the medial lemniscus, lateral lemniscus, and spinothalamic system, and we found that the spinothalamic pathway tract is associated with the posterolateral part of the hypothalamus. It controls sensory pathway from the skin. We see sagittal view of the spinothalamic tract, the yellow one, and the TI images, this one, another specimen. And we see frontopontine tract, purple, and DTI images. Again, corticospinal tract we see pink fibers. Temporoparieto-occipitopontine tract is a large tract. Again, anterior view of the corticospinal tract from another specimen. You see here. Frontopontine tract, different view, anterior view. Now, dentorubro-thalamic tract. It originates in the dentate nucleus and terminating in the contralateral red nucleus, thalamus, and posterolateral hypothalamus. It controls bilateral leg movements. Blue one, we see dentorubro-thalamic tract and DTI. Supraoptic commissure. This tract was demonstrated and described for the first time in our study. Supraoptic commissure contains 3 groups fiber and connects the hypothalamus, subthalamus, lateral geniculate body, tectum, and usually dorsal fibers group. They are associated with the anterolateral part of the hypothalamus. Again, frontopontine tract, another specimen with DTI images. Corticospinal tract we see. Temporoparieto-occipitopontine tract, another specimen. If we sum the off tracts we have talked so far, diagonal band of Broca, ventral amygdala hypothalamic fiber, fornix, postcommissural fornix. These tracts related to the anteromedial hypothalamus region. The other one, frontopontine tract, supraoptic commissure, and cingulum related to the anterolateral hypothalamus region. Dorsal and medial longitudinal fasciculus related to posteromedial hypothalamus region. It's a crowded group. Fasciculus mammillaris princeps, mammulotegmental fascicule, corticospinal tract, temporoparietal, occipitopontine tract, medial lemniscus, spinothalamic tract, dentorubro-thalamic tract, and medial forebrain bundle related to the posterolateral hypothalamic area. Mammillothalamic tract and fasciculus retroflexus related to the posterior hypothalamus region. To summarize, anterior hypothalamus has paraventricular, chiasmatic, preoptic, supraoptic, and anterior hypothalamic nucleus. And this provides emotional regulation. So, anteromedial or anterolateral tracts can be used as a target in the treatment of depression, obsessive compulsive disorder, or behavior problems. And posterior hypothalamus has ventromedial, dorsomedial, infundibular nucleus, mammillary nucleus, and posterior hypothalamic nucleus. And this controls some body rhythms, circadian rhythms, etc. Posterolateral and posteromedial tracts can be used as targets in epilepsy, headache, movement disorder, tremor, or dystonic disease. And we look at the literature. There are many studies on use of such targets. For example, some studies. Shortly, hypothalamus is a very important and complex area for neurosurgeons. Therefore, it is a target area for future studies. So it's important to know its anatomy and connections. Thank you for your invitation and for listening to me.
Thank you very much, Professor Belenko, for this amazing presentation. And you are really expert of the hypothalamus. Now we will open if there is anyone has any question or any remarks for our speakers. You can either ask in the chat or ask directly if you like. Actually, there is no any questions in chat. Okay.
Dr. Penny, congratulations for the nice talk. It's difficult to understand all these connections. Is impressive how the hypothalamus is connected to everywhere.
Very complicated, yes.
Have
Yes.
a lot of information there. Very nice to have it.
Thank
To have
you.
it for review. Very good.
So I guess there is no any questions. So thank you, Dr. Eduardo Ribas, and thank you, Dr. Birin Kodok, for your amazing presentations and the very nice lectures. And we are honored by your joining us and participation with our program. Here I can see someone ask, any tract from hypothalamus to pineal gland?
No, I didn't study with pineal gland.
So
It's
there is no
another
connection.
study, I think.
But is there any connection between the hypothalamus and pineal gland, or?
No, I didn't see.
Okay. So there is no more questions. So I think by this we can conclude our ninth session. And we thank you again, Dr. Eduardo Ribas and Dr. Ibrahim Kodok, for these amazing presentations and very nice information. And see you, inshallah, in the future presentations. And to all our audience, I hope you can join us next week, next Friday, inshallah, also at the same time. And I think we can conclude. So thank you, everyone.
You, friends.
Thank you.